Hello, do we have the clinician with us?
Oh, hey, no, it's just me.
Okay, thanks. We're still waiting for the clinician.
Okay.
I wasn't doing the waiting music, though.
Hello.
Hello, is this the clinician?
This is the clinician. Hello.
Wonderful. Thank you so much for joining us.
It's my pleasure. I called in actually twice. I'm glad that we were able to get through.
Yes, me too. So glad glad to be able to talk. And I know we rescheduled once before, so thank you so much
Yes.
for making the time to talk with us. And
That's why I was worried a little bit about the connection.
Okay, yeah. Well, if it drops out for any reason, we'll wait for you. We'll be on the line,
Yep.
Waiting for
I'm
you
happy
to come back.
I'm here. I'm not going. I'm all yours for the hour.
Okay, wonderful. So first I'd like to start with discussing a little bit, and, as the pre-recorded call mentioned, it is anonymous, so we don't need to know your specific name, but we'd love to hear a little bit more about your background in terms of your practice, experience, type of clinician, and then I have a few more questions that we'll dig in there, but maybe we can start with that.
Absolutely, not a problem. So I am an associate professor of multiple departments, including anesthesiology, family medicine, and physiatry. And I am triple boarded, really. I am grandfathered into regional anesthesia. I have fellowship training in pain medicine. I also am grandfathered into hospice and palliative care. I spend a portion of my time doing acute pain medicine and covering an entire academic hospital institution, and also the other half of my time with an outpatient pain practice covering chronic pain. So I have a pretty unique role and identity in both the acute pain setting and also in the chronic pain setting, which is wonderful for me. I love what I do. I work in a large academic medical center covering residents, fellows, medical students. I am also the program director of regional anesthesia. Hello?
Can you hear me? Hello?
I can hear you, but I don't. I was talking and I must have hit mute with my cheek. My apologies.
Okay. Yeah, I can hear you now.
Good,
you were
good.
saying
I'm so glad.
yeah, I can hear you now. So you were saying you're at a large academic center where you are leading a program that includes residents, so a lot of medical education as well. I think that's where I cut off.
Oh, okay, sure. I also am in charge of, so residents, fellows, medical students, we're affiliated with a medical school. I have run multiple rotations. I have run the entire acute pain division for multiple years. We have more faculty now, but as we started. And what else do I do? I'm also, I think I said I'm the fellowship director, and I do everything I can to be dedicated to my patients and to do a good job, and I care a lot. I work in a very large urban environment, and so the pathology of the people that I take care of are very, very sick and have a high morbidity, frankly, and so for that reason, I have interesting patients that are complicated, and I do my best to take care of them.
That's wonderful to hear. And can you tell us a little bit, this is just data we're collecting on everyone, about how many years you've been in practice post-residency?
Oh, I'm so sorry. I completely forgot to mention that. So I have been in practice for 11 years, 10 after fellowship. I'm in my 11th year.
Okay, great, wonderful. And in terms of the types of patients you mentioned a lot of high morbidity patients. Can you tell us a little bit about the types of procedures?
I'm sorry, you faded out for a moment. Can you just repeat that, please?
Of course, yes. Can you tell us a little bit about the types of procedures of patients that you're covering? Hello? Can you hear me?
Hello?
Yeah.
I was saying, are you talking in terms of acute pain, in terms of chronic pain, in terms of the operating room itself, just so I'm clear on
Yes. Yes. Specifically on the types of operations and procedures in the OR.
No problem. So the kind of surgery, so I'm part of a large joint replacement. My week, I am involved with every orthopedic procedure that you can imagine. In addition to that, we have a large vascular service, general anesthesia service, and I happen to be one of the attendings who is asked to deal with a lot of the emergencies. So I cover the acute emergency operations, such as everything from appendicitis and cholecystectomies to exploratory lap cases to splenic artery ruptures, you name it, they could call me in for any of those cases.
Okay, great. Well, that helps us understand a little bit more, and it's definitely an area that we want to continue to dig in on to find out your specific thoughts on, both pain management, but first I'd like to just try to understand, if you think about perioperative clinical care, so specific patient conditions, can you share a little bit what comes first to mind for you in terms of what are the most challenging problems to solve in perioperative clinical care?
I can give you a list. We only have an hour. Is that true?
Yes. Yeah. So maybe your top three. What are your top three?
Well, I think that, so I spend a lot of time covering regional anesthesia, so everything related to nerve blocks, which also does include epidurals and spinals and that sort of management. I'm very interested in ERAS and acute pain protocols, so that combination and that point of perioperative management so that we can properly transition people from the preemptive analgesia, the PO environment preoperatively, to whatever they're getting in the operating room, to everything that they're getting post-operatively. So that includes all of the different ERAS, algorithms to get people out of the PACU faster, out of the hospital faster, to maintain patient satisfaction, to do a good job and be a good doctor. And then I think the last, if you're only limiting me to three, I'll behave for now. Maybe you'll give me four.
Sure, yeah.
I would be